let me introduce Candy Stockton, the health officer in Humboldt County, and Erica Dykehouse, who is the public health nurse in Humboldt County. And we have been working together with San Francisco on a very complicated patient who I'm going to put his summary course up on a screen. But if you don't mind, Erica and Candy, I'm just going to quickly review the salient points of him so that we have something to talk about. So this patient was 53. He was US born. He had never traveled. He was reportedly otherwise healthy, so not really known to have any TB risk factors. He worked in the service industry. And after years without any major health issues, he began to experience symptoms and seek care in local emergency departments for various concerns. And that included generalized body swelling, weight loss, episodes of syncope and falls for 4 to 6 months. And he actually ended up being airlifted to San Francisco General Hospital because he was very medically complex. So while at the General Hospital, he was actually diagnosed with disseminated TB, including of his lungs, of his eye, of his prostate, his liver, spleen, and adrenal. And he also had a lot of abdominal fluid, which showed that he had TB, and also TB of his gut as well. So he had really TB extensively throughout his body. He was quite ill. He was also newly diagnosed with cirrhosis with ascites, and he may have had a remote history of alcohol use. So he was started on TB treatment, but he had a lot of complications. He had a pulmonary embolus, he had acute renal failure, perhaps due to contrast dye. He may have had a drug reaction to one of the TB medications with systemic symptoms, which caused him to have worsening pulmonary findings as well as a rash, and for which he required high-dose steroids. So after several months at SFGH, he was finally stable enough to be transferred back to his home in Humboldt County. And that's where I think the real heroic work comes in, frankly. So I have with me Candy and Erica was the primary public health nurse who was receiving this patient. And so if it's okay, Erica, I'd like to ask you a couple of questions about, you knew this patient when he came over and you knew you were getting him back to help with his care. So initially, what were the challenges that you thought about in getting this patient back home to Humboldt County from SFGH? Because he was quite complex, and I recall he was so weak we weren't even sure he could make the taxi ride or car ride back, just because it was going to be a long, uncomfortable journey for him. So would you mind helping the audience understand the challenges with how to take care of this complex patient in your county?
I think Dr. Stockton was going to give a bit of an overview about just some of the general challenges are just receiving a patient in general in Humboldt County, if that's okay.
That would be great. We want to hear.
So I'll talk just a little bit about the general medical situation. So Humboldt County is a rural county, only approximately 135,000 people spread over a little more than 4,000 square miles. So it's a large area with a lot of people living in remote rural communities in the mountains or back in the valley area that are distant from any of the areas that have medical care in them. So we have a severe shortage of primary care medical providers locally. So a typical patient like this who was not receiving medical care from a primary care provider prior to him being diagnosed with this illness may have to wait anywhere from 3 to 12 months to actually be able to establish with a new primary care provider.
Wow.
And
Wow.
it may not be one that, is practicing within an hour of where they live, which if you can imagine, if you're not able to drive yourself and if you're needing medical transport to appointments, how difficult that would be, especially because this was in the early stages of the pandemic prior to the time when everybody was really converting over to telemedicine, which helps a little, but in a lot of these rural areas, there is no access or no reliable access to internet or Wi-Fi. So having the ability to do telemedicine appointments, while it's helped a segment of our population, doesn't actually reach our most remote citizens. So, I mean, that's just kind of the most basic, is just the physical problems with getting transported back up here, being able to find a doctor or primary care provider who's able to coordinate all of the care that somebody like this would need, And then you add in things like access to medications. There may be no pharmacy within an hour or two of the area at which you live, and a lot of our rural residents can't receive mail delivery directly at their properties, so they have to travel into a post office box or someplace else to get deliveries, and not all mail order companies and pharmacies will deliver to post office boxes. So there's a lot of logistical difficulties just in caring for anybody who's chronically ill to begin with. And then you add in our really small county size, which means that we don't have a lot of specialty services locally. It takes a certain amount of population to support any given kind of specialist. We have one infectious disease doctor in the county. So there's that lack of access to the specialty services that are needed to coordinate, and just a really difficult situation to be in. And then we may go 2 or 3 or 4 or even 5 years between having a case of active tuberculosis in the county. So being able to keep our skill set up to be able to manage the patients when they do occur is really difficult. Most of our primary care doctors in Humboldt County have never worked with a case of tuberculosis. And actually on any given day, most of our health department has never worked with a case of tuberculosis. So it's a unique situation, definitely.
So what you're saying sounds really, really challenging, just knowing that our typical TB patients are taking 10, 12, 14 pills a day. We need to regularly draw their blood, check in on how they're doing, watch out for side effects, do things like get regular eye exams, take a look at, whether there's a rash or not, check their liver function tests, look for any problems with neuropathy. So many things to track with TB. And it sounds like you even just had a hard time just getting a regular doctor for this patient and insurance because he hadn't had established care before.
Right. And in many of the rural areas, there isn't actually home health services available to send out for those things. And actually, the county itself doesn't have any commercial laboratories. So our laboratories are all associated with either the hospital or the clinic that they're based out of, which means like just, sending him to an outpatient lab isn't even a possibility.
Right. This sounds really hard. And this patient I don't think he was able to drive himself. He was not mobile. So all of this needed to be figured out. The moment you heard he's coming, which the hospital has its own challenges with trying to get discharges moving because they, were at capacity because of COVID. So lots of different competing challenges with everybody. So in this patient who had disseminated TB and needed to have daily TB meds and monitoring, how did you perform the directly observed therapy and how did it go? And how did monitoring go for him?
I think in some ways, I don't think we differ from other programs. Home visits are performed initially for DOT. We do med box fills and then a patient assessments by a public health nurse. We typically assess the patient for a short period of time to determine if they're a candidate for video DOT. Mm-hmm. And then we convert from DOT visits to video DOT visits after we determine that patient, meets the requirements for that, if they're stable enough that they can meet those requirements. Unfortunately, for this particular individual, for a variety of reasons, they did not meet those requirements for the first 5 months of treatment. So they were home visits 5 days per week for the first 5 months of treatment, except for the time periods when they were, of those 5 months when they were at the hospital. Where we do differ significantly is that the distance we may have to travel to reach our patients. One TB visit may require 2 to 4 hours one-way travel to arrive at the patient home. So it can take an entire workday just to do one home visit. So it's not really reasonable for us to do daily DOT visits. We would have a staff member spending their entire week doing just DOT visits if we did that. We coordinate when we do that to maximize that visit. We assess the patient, deliver supplies and incentives. We obtain signatures on the forms when we go out. Continue our in-person contact investigation while we're out in that area. And then we greet local healthcare providers in that area and in the labs to provide education and information when possible. So when you do make that trip, you get as much done as possible. You do a lot of planning prior to just even your first dot visit to see a patient in a remote area.
And I can imagine, Erica, this patient did not live with anyone else, if I'm remembering right. So you really had to do everything you could to get everything you could out of him. How are you doing? Are you able to go to the bathroom? Are you able to feed yourself? How are you getting food? Because he was, on his own. So not only are you doing a lot of TV care, you're doing a lot of social work, actually.
Yeah.
In this, quick hit that you have, this short time that you have to make sure the patient's doing well globally, not just from a TV standpoint, because he had a cirrhosis to manage. He had, a lot of other chronic problems that came up as a result of being hospitalized here and his TB diagnosis.
I think that's
So,
one of the things that you pick up when you do a home visit. That's one of the advantages to a home visit is you sometimes don't have to ask questions, because if you've been at a home visit repeatedly, you can look around and you can note differences. You can note whether the home is tidy, what wrappers are laying on the ground, with it's a trash can been empty, little things that you can pick up on.
alcohol bottles or something if a
Right.
patient's a drinker.
You're able to
And
assess the environment and as well
yeah.
as the patient without even having to ask questions.
And you also had to spend, I recall, or nurses spend some time also talking to family members to kind of keep them in the loop on how patient might be doing, or whether they need support, or what support's available, how far away they live, who's taking care of his pets, things like that, right? Because he had some pets he was worried about while he was hospitalized for so long.
Yeah,
So,
one of the questions you had asked in it was about, what did we do as the patient deteriorated? And because we weren't able to establish with consistent case management because of just the issues in general with inconsistencies in healthcare. So we as public health kind of became the de facto case management.
yeah,
This particular patient.
were you eventually able to find a primary care doctor for this patient locally?
The provider, the patient did have a primary care provider established, and he still does have a primary care provider, a consistent primary care provider, but that's not the same as a case manager who would make sure that follow up to make sure that all of the forms are completed for transportation, that any assistance with disability forms are completed, that social security, permanent social security forms are completed, that applications for Medi-Cal are completed, applications for a parking placard are completed.
Yeah.
Coordinating with home health to make sure that they come on time if they're available, all of those case management things that the patient needs, but that don't fall under tuberculosis and don't fall under primary care. The patient really needed that kind of case management.
Yeah, things that are just really important that, most people take for granted. But I remember this patient, for example, I don't recall that he had a bank account. He had a hard time finding a way to pay his bills, even though he had money, just kind of getting that process going because he didn't have anything electronically set up. And so that kind of fell on his shoulders, but because he was not quite, I think, ready to take on all that, also the case manager's shoulders.
I think a lot of times in like we were talking about in rural communities is that when you don't have high-speed internet access, people don't often you can't count on technology. You don't set up electronic bank accounts. You don't set up to do e-banking. Everything is done in person. It's really important to have those brick and mortar facilities for those reasons. And we have those same challenges like with video dot. I often have difficulty determining if a patient has really not performed video dot for a week, or if they simply haven't left their remote location to go to the store or anything, where if in the remote location they may not have cell phone reception, so we have to wait until they have a reason to leave their home, to go to the post office or something else where they would get cell reception, and all of those videos would upload and send to us.
Wow. These are things we take for granted here. We're not going to, every time we talk to rural partners, we never complain after about what we do. Candy, did you want to add something?
I was going to say actually that, how appreciative we are of the collaboration between the expert consultation that you guys provided in the infectious disease component of that care. But how I really do want to call out that Erica just kind of breezed over the fact that, yeah, he got a primary care provider, but our public health nurses who served as, Erica and other nurses who served as the champions for this patient, when we say, oh yeah, he got a primary care provider, what that actually entailed was Erica and her colleagues getting on the phone and calling everybody they knew at surrounding clinics and trying to sweet talk somebody into agreeing to see this patient.
Into taking him, right?
Yeah, so I mean, so it almost sounds like that just magically, oh, of course there was a doctor, but even that required a significant investment of time.
Of work, right?
Just to find somebody who would be able to see him and do that. And we are so fortunate that we have such dedicated public health nurses working with our patients.
And then how did he get to appointments? Did you have to drive him, or how did he arrange? How did he get his labs drawn? How did he get to the doctor? These are all things we take for granted here, but I want to hear how that's done in your county.
Transportation in general is a problem in rural areas. It was a big shock for me when I moved to California. Bus lines, I was surprised to learn, they may run. The closest bus stop could be 7 to 90 miles from your home. So there is a bus that runs to the town, but you still have to find a way to get to that bus stop. So consider that a round trip drive just to get to the bus stop could be $45 in fuel costs.
Wow.
Is, in order to get through mountainous areas, you have to have a 4-wheel drive vehicle or an all-wheel drive vehicle. Those average about 18 to 22 miles a gallon in fuel efficiency. And, you have to go 90 miles one way to get to the bus stop. And then you still have to pay the bus fare and all of that time sitting on a bus just to get to town to go to an appointment. There's no Uber, there's no Lyft, there's no taxi, and if there is that option available, it's going to be equally cost prohibitive. A full round trip drive, if you have access to a vehicle, a good reliable vehicle that can go that far, imagine that's going to cost $100 in fuel costs just for one visit to the coast. That's what we refer to the town.
How did this patient manage to get to and from doctor's appointments and lab draws, and also sputum? How did you get sputum out of him? How did all these TB, metrics? How did you get those accomplished?
It was a hodgepodge. Sometimes walking together. Sometimes transportation had been arranged when there had been a case manager, an appointment had been scheduled, and transportation had also been scheduled through the insurance company. Sometimes appointments were missed because an appointment had been scheduled, but transportation had not been scheduled. So the patient would be standing outside of their home waiting for the ride that never came, and then ultimately would have to call and let them know that the provider's office know that transportation had never arrived.
It just sounds like
blood
it was
draws. One time the patient needed a critical blood draw, and I believe the PCP went to the patient home and drew the blood.
Okay. Wow. And then, as you, I think, alluded to, this patient did start to have some adverse events to some of his TB medications, and that's the same challenge we have here in San Francisco. We find that about a third of our patients have some adverse events, and so that sounds like, with all the challenges you're already having, how do you assess those, and how do you get those, looked at by a specialist? Or that also sounds challenging, but then you're kind of more of a you need to have it looked at pretty quickly as best you can.
We called you a lot.
Happy to help, but I'm still not there. I don't have my car up there.
On multiple occasions, we did dot daily. So that was the main reason that we were doing in-person dot Monday through Friday still, was because there were so many complications and the patient situation. And we do that as often as we can, as often as we have staff available and as patient need requires. And
I think-
also
Go ahead.
to account for, you know, to still allow patient privacy too.
Yeah.
You want to go to video dot as quickly as possible. But in this particular instance, there were 3 occasions when we arrived and had to call an ambulance. In one instance, the patient experienced anemia and the hemoglobin was measured at the hospital. It was below 5. Another time, I arrived and the patient had been experiencing gradual vision loss over the weekend from a thiambutal toxicity. And another time, there was just gradual, well, actually not gradual, but rapid decline with inability to ambulate. And in that instance, I did end up speaking with the patient and calling the patient's family from out of the area to come to assist the patient, and eventually did call and try to get placement in the hospital.
Yeah. Yeah. And I mean, I know Candy was describing how there are not that many tertiary facilities in your county. So it sounds like the hospitals and ERs that the patient was seen at were trying their best, but it's just very challenging when you have this level of complexity in a patient and these, you know, really scary side effects that you just hear about them. You're like, oh, what are we going to do? I
Right.
can imagine. It's really
And
heroic.
being in a county where we rarely see TB cases, so this isn't something, you know, that our ER docs may have seen. They may not recognize the potential for it being a complication of tuberculosis treatment because he had so many other concurrent health issues.
Yeah.
And I mean, I think this is no shock to anybody, but an emergency room is not the best place to get coordinated care. Their job is really to decide, are you going to die right this minute or not? If not, then they send you home to sort it out with your medical team. And that's really problematic, you know, for a patient like this who has, you know, who just doesn't have access to the treatment that he needs to figure that out. And it doesn't help that this was occurring in the middle of our COVID surge locally when our hospitals were barely managing to stay staffed and functioning as it was. And so it just, I mean, added a whole nother layer of complexity to what would have already been a really difficult case.
Yeah. Yeah. I have to mention this was a global effort because he was also followed by a UCSF ID doc. So it wasn't just you, it was all of your collective ERs and hospitals and public health nurses and primary care people and local specialists. Your department, Candy, we helped a little bit. The state department helped a little bit, state TB branch. There was a UCSF provider involved. So it really was a global effort, even though all of us were watching from afar.
And it wasn't just a little bit. I mean, we needed to be the hands and feet on the ground to make the contact here, but we would have been completely lost without the support that we got from you and from the state. That we do not have the skill set necessary to provide the care this patient needed. We have some level of manpower, we have a lot of passion, we have a lot of dedication to our work, but we could not have provided the care this patient needed without the assistance that we got from you guys and from the state.
Yeah, and so I think to wrap up what happened with this patient, he ended up back at the General Hospital in San Francisco. His medications were adjusted, and any concerns we had or you had as far as his anemia and his vision were all looked into. So he got the whole overhaul, you know, in the body shop. And then he went back to your county and then I think was on treatment for another year. So he actually was your patient for at least a year and a half, which is a long time to be on TB medications, a long time to do daily DOT, and a long time to kind of worry and manage the side effects along with all of his other issues, social issues and getting, you know, transportation issues, everything. So Erica, I know he was your first TB case actually. So looking back, what would you like the audience to know about your work? And Candy, feel free to chime in because from our eyes with what you've done, it was amazing. So, you know, just the audience that you're talking to is mostly lay people or lab people or researchers, and so they really want to hear what it is on the ground as far as how we're actually taking care of these patients and, just everything that we do. That's what World TB Day is about. So when you think about him, Erica, like what relief, he's
I think the hardest thing was setting boundaries. It was so difficult to say no sometimes to see a patient with so much need, and it continues to be that with all patients. When you have a county where there's so many patients with so many needs and there are so many voids, it's tempting to fill that void. And it actually takes a lot less time to do something for a patient than to try to find a solution. It would have taken me less time to do some of the things I did than it did to think of, let's call the family, let's get the family to come down here to help out now. And then it can't verbalize, but just to say that when you have to say no, it's even harder than it is to just do things for patients.
Yeah, you're a nurse, so you want to do everything, right? Candy, do you want to add anything?
I will just add that this was actually also my first TB patient. I'm new in this role, and so I'm well versed in how difficult it is to take care of patients with chronic illnesses in rural areas. I've been doing this for 25 years. Like, that piece wasn't new, but I honestly was blown away by the level of support that's available to us. That was kind of one of the scariest things for me when I walked into this job on the first day and we're like, oh, by the way, you've got this. And I'm like, I don't know anything about this. My whole career, I treated like 2 cases of latent TB before this. And so I will say that I am just really impressed by how much support is available to us smaller rural communities when we're faced with these kinds of problems. And also a little sad, I think, that we as rural communities don't do a better job actually educating each other about the support that's available, because I think we don't always know that help exists or how to reach out to. So we're very fortunate, that we came to this patient in combination through you after he'd been diagnosed in San Francisco, so that we got plugged into that support network immediately. And to anybody else in rural communities who are struggling with this, like, reach out and ask, because there is a lot of help out there, and it was invaluable for us.
Well, the partnership continues, and we learned a lot from you as well, because he was also a puzzle when he got here, and many world famous ID people were puzzled by this patient and why he was so sick. He didn't have any TB risk factors. He was just someone living his life, and then he ended up with this horrible, complicated disease, and a lot of people puzzled over him. So I think he was a learning opportunity for you, for us, for UCSF, for SFGH, for everybody. But he actually was such a lovely person that, of course, we all wanted to come together to help. So I think, I know both of you now pretty well, so I'm not going to be great at asking questions that are, probing or deep, but I think you've explained what you've gone through. And again, I wish we had a picture of where you are, so that, I'm sure people in the city are kind of like, well, why would you work there? But it's so beautiful that I think that's why this patient wanted to go home, because, it's a beautiful place to live too. And it's a great community. So, thank you for giving us a picture into what it's like into rural TB healthcare, and forever you'll be my hero. So thank you for your time. Do you have any last thoughts that you want to share?
I do. I did want to add how critical it is to have the support system, the support network. I know that when I initially got the case, the first thoughts that went through my mind was, I don't remember anything about TB. And I reviewed my notes, and then after reviewing my notes, my first call was to our CDPH TB control branch liaison. And I called Leslie Henry, and my notes say, is there a checklist? And she gave me a rough checklist to follow that was super helpful. And then the next calls were to, in the checklist, were to contact the nurses in the public health branch that has the actual patient. And I was able to speak with your team there in San Francisco. And I talked with Anna Lee
Yep.
and with Felix, and we've been collaborators ever since on many, many cases since that time.
Yeah.
Thank you very much for your support and for all of your guidance.
I wanted you on not for you to thank us, but to like
I know, but
have you represent what, is a great part of rural healthcare is the dedication.
but people need to know that it's okay to ask questions. It's okay to say, I felt like I should have known the answers. Like I had been to all of these trainings at the Curry Center, and part of me was too proud at first to say, I don't know. And I wanted to find the answers in the book, but I needed to get those answers more quickly and to be able to just say, hey, wait a second, what am I supposed to do? What forms am I supposed to ask? It's okay to just ask another colleague. I don't remember. I know that I've been through this training before. What am I supposed to do again? Can you refresh my memory? It's okay to ask. It's okay to not know.
Especially once every 5 years, you have to have that refresher, right? Okay, well, thank you so much for both of you to participate and share your experiences with the community on World TB Day. I really, really appreciate working with you. So thank you.
Bye.
Bye-bye.